Medicine Fellowship. My research interests are chronic respiratory failure, particularly in COPD, home ventilation, and I also do some work with stroke and sleep apnea, as well as sleep in the inpatient setting. By the end of this talk, we should be able to contrast the different indications and guidelines for non invasive ventilation. We should be able to differentiate the different devices as well as modes used in non invasive ventilation. We should also be able to formulate pathways for management of these patients in the sleep center. Hypercarbic respiratory failure is defined as a pathologic elevation in carbon dioxide at 45 or above. And patients may typically complain of morning headaches, sleepiness during the daytime, or signs and symptoms, or have signs and symptoms of pulmonary hypertension, such as leg swelling and shortness of breath. The American Academy of Sleep Medicine defines sleep related hypoventilation as an elevation in carbon dioxide to greater than 55 for at least 10 minutes, or increased by at least 10 compared to wake CO2 to at least greater than 50 for 10 minutes. And this definition is paying homage to the pathophysiology of hypoventilation as it occurs first in sleep. Sleep sleep related changes in respiration, including nocturnal desaturation, have been shown to be a greater predictor of hypoventilation, particularly during sleep, compared to vital capacity or maximal inspiratory pressure, which are daytime measures of respiration on pulmonary function testing. Nocturnal desaturation is also a greater predictor of mortality, particularly in patients with neuromuscular disease. So, why is this so challenging during sleep? So, with normal respiration, particularly when we're upright and awake, the line of action of the diaphragm is downwards. The diaphragm's not depicted here, but it pulls the lungs downward to allow air to enter and leave the lungs. The line of action of gravity is also downwards, and so gravity is able to help the diaphragm. But when we're laying down, the line of action of diaphragm is lateral and the line of action of gravity is downward. And so we lose the assistance of gravity in our respiration. This becomes much more prominent in patients with neuromuscular disease, where the simple act of laying down is challenging because of the degree of diaphragm weakness. And the deeper into sleep the patient gets, the more relaxed the muscles get to the point where there's complete paralysis in REM sleep of all muscles except the diaphragm. It's therefore very important for practitioners taking care of patients with respiratory disease to pay attention to their sleep. This is a depiction, particularly of the EMG, showing progressive relaxation during deeper stages of sleep. So, the role of non invasive ventilation is to improve various respiratory parameters during sleep, also to improve various respiratory parameters during wake, and thereby affect improved quality of life, readmission rates, and mortality. The HOT HMV study by Murphy and group showed that non invasive ventilation prolonged time to readmission in hypercapnic COPD patients from 1.4 months in the oxygen only group to 4.3 months in the non invasive ventilation group, with, of course, the addition of oxygen as well. The rate of admission free survival also had a trend to improvement in the non invasive group compared to oxygen alone. This is also seen in terms of improved survivorship with non invasive ventilation in patients with obesity hypoventilation. This study shows that in the dotted line, untreated obesity hypoventilation has a lower survival rate compared to the solid black line of improved survivorship over time in patients with obesity hypoventilation treated with non invasive ventilation. We'll now review the indications for non invasive ventilation. Clinical guidelines and reimbursement guidelines will be contrasted here because they're not necessarily in alignment. And non invasive reimbursement guidelines are being written for better alignment at this time. In the US, non invasive ventilation starts with bilevel, particularly bilevel S, which is different from how it is elsewhere in the world, and therefore will be primarily focusing on the United States. With this current table, I've displayed on the left column CMS reimbursement guidelines, and on the right, an ATS practice guidelines. So currently for COPD, we can order non-invasive ventilation if the carbon dioxide is elevated above 52 and there's hypoxemia on nocturnal oximetry showing oxygen saturation less than 88% for at least 5 minutes on 2 liters of O2, or the patient's daytime O2 flow, which means that if the patient is not on any oxygen during the day, the nocturnal oximetry needs to be done on 2 liters. And if the patient is on 4 liters, for example, during the daytime, then they will need to be on 4 liters for the NOC-OX. The ATS practice guidelines suggest treating carbon dioxide greater than 45, and they do emphasize that the blood gas to demonstrate the hypercarbia should be done 2 to 4 weeks after an acute exacerbation to ensure that the patient is in a stable, compensated state. They do recommend avoiding titrating NIV in the sleep lab, which contrasts with the AASM's stance. For obesity hypoventilation, Medicare and CMS recommends treating when there's moderate sleep apnea or mild sleep apnea with comorbidities. And we do need to show that CPAP was tried and failed. For obesity hypoventilation, ATS guidelines recommend diagnosing OHS when sleep apnea is seen on the sleep study and then arterial blood gas shows carbon dioxide during the daytime greater than 45. They do recommend CPAP as first line treatment for outpatients, particularly if AHI is greater than 30, putting them into the severe range. They also suggest that patients hospitalized with hypercapnic respiratory failure should be discharged with home non invasive ventilation with subsequent testing in the next 2 months. For patients with neuromuscular disease, there are many different methods to obtain non invasive ventilation, including arterial blood gas, nocturnal oximetry, or PFTs, as demonstrated here. There are no ATS clinical guidelines since 1999. So I've also kind of brought up the newer recommendations to Medicare to kind of reevaluate their um, current reimbursement guidelines. This has been put forth because current CMS guidelines and the clinical practice guidelines do not align. And so this on-map technical expert panel was kind of put together to make recommendations to CMS to actually just update the knowledge based on what we know. So the current on-map, the new guidelines or proposal to the guidelines recommend treating still for CO2 greater than 52, but they've eliminated the nocturnal oximetry requirement, and they do advocate for use of a bi-level device with a backup rate, and they elaborate further to provide greater clarity on when to advance to more advanced home ventilation, which we currently actually just don't have any guidelines for. With obesity hypoventilation, they still do, for hospitalized patients, they now recommend reimbursement for bi-level with or VAPS device with a backup rate at hospital discharge. And they suggest that for ongoing coverage, there should be a need for evaluation and also a sleep study within about 3 months after initiation. For neuromuscular disease, they've expanded the opportunity to treat hypoventilation to patients who might have, a much higher vital capacity of 80% even, so long as the patient has symptoms of hypoventilation, such as shortness of breath, morning headaches, or poor sleep quality. They've also expanded the carbon dioxide to include end-tidal CO2 or transcutaneous CO2 measurements, or even venous blood gases. And they've also included that if a nocturnal desaturation is seen, that PSG or home sleep testing is also acceptable, whereas currently it's not. So overall, these still remain recommendations to CMS, and CMS has to determine whether they will accept these recommendations. We'll now go through a case to see how these guidelines apply to our patients. So this is a 65-year-old man with history of severe COPD, very severe COPD, who's admitted with an acute exacerbation of COPD. He had 3 admissions in the past year, and he's enrolled to a quality program we have at my center called Proven Care COPD to ensure the patient's testing and treatment meet our guideline recommendations. And so his serum bicarb is chronically elevated, and this admission triggered a venous blood gas testing, which showed a high carbon dioxide, which then triggered the algorithm for arterial blood gas testing. His carbon dioxide is 102, and he's therefore treated for that acute exacerbation with steroids and inhalers. So, what is the appropriate management of this patient per the ATS guidelines at discharge? Should we check a nocturnal oximetry? Should we start bi-level? Should we start home ventilation? So I've listed an example of home ventilation, the Respironics Trilogy Evo. Should we check an arterial blood gas at 2 weeks from discharge? So giving you guys a moment there. The correct answer is that we should check an ABG in about 2 weeks from discharge. So in 2 weeks, the patient comes back to clinic and the carbon dioxide is still 102. So nocturnal oximetry also demonstrates hypoxemia. So what do we start? What do we check? So we end up choosing bi-level, and we end up trying to target, eventually in a couple months, we want his carbon dioxide to be normalized per ATS guidelines. And we also need to be able to see him after day 61 to demonstrate that he's using his device for at least 4 hours per night. So How do we choose different modes for the patient and what are the advantages? We'll use this opportunity to talk about the different modes of non invasive ventilation. So, in this table here, on the left, I've kind of included my hand drawn doodles of potential waveforms from different modes of ventilation. And in the middle column here, the settings that could be changed. And on the right, the different advantages and disadvantages. So with bilevel S, it's a modality we often use in sleep medicine, particularly for obstructive sleep apnea. We have the IPAP and EPAP. It's low cost, it's easy to obtain um, per reimbursement guidelines, and there might even be some breath to breath data available so we can look at that information on cloud systems. With bilevel ST, again, another modality we often use in sleep medicine. And there is an IPAP and EPAP that are measured, and a respiratory rate, and pardon me, an IPAP and EPAP that we can set, as well as a respiratory rate and inspiratory time. Um, I kind of starred the inspiratory time because of the differences between different manufacturers. Specifically, if we look at the little doodle in the left panel under the word bilevel ST, we see that the spontaneous breaths, which with an S on top of them, the two different breaths I've depicted here have two different um, widths. And the width is different because the amount of time the patient spends in that is different. And so, with particularly Respironics devices, even in the ST mode, it does not regulate the I time for the spontaneous breaths and only does it for the timed breaths. Whereas with the ResMed devices, inspiratory time is better assured even in the ST mode. With the next mode, more advanced mode, is the pressure assist control mode, where we can set an IPAP and an EPAP, respiratory rate, and inspiratory time, perhaps a range. And what you'll see is that the shape of the breaths is consistent from breath to breath. No matter what the manufacturer, it still regulates the inspiratory time. And the inspiratory time is so important because even with lower pressures, we can achieve better tidal volumes, larger tidal volumes, if our inspiratory time is a little bit more prolonged. Um, there's also a feature in pressure assist control modes in either of these manufacturers where you can turn on volume assured pressure support, which is a mode so that the IPAP or upper pressure can be changed by the machine to target a specific tidal volume. We'll go through examples of that later on. I also wanted to make sure we talked about AVAPs and IVAPs, which are two different brand names for by two different manufacturers. I just wanted to highlight the differences between the two because they have different features and they are not equivalent. So AVAPs is a technology that's and a mode that's utilized in Respironics Trilogy devices, the 100 and Evo, which are more commonly used, and the V60, which is used in the inpatient setting. With that, you can set a IPAP max or a PMax and an IPAP min or a PMin. And the EPAP can either be a fixed number or you can set an automatic EPAP. You can set a respiratory rate and an inspiratory time, keeping in mind once again that for spontaneous breaths, the I time is not regulated. You can also set a tidal volume, and the device is able to, first, adjust the automatic EPAP for supporting the upper airway, for example, if that is chosen. and then modulate the inspiratory pressure or Pmin between the lower and upper thresholds we set to target a tidal volume. The difference between this AVAPS mode versus even a pressure control mode with VAPS is that, particularly in the Respironics devices, it has a very the pressure control mode tends to have a fixed I time. The IVAPS in the ResMed brand is actually different. And what that targets is not a tidal volume, but rather the alveolar minute ventilation based on the patient's height. And you can still set a uh, maximum and minimum EPAP to address upper airway once again. But you can also set a respiratory rate that's expected, and you can set an upper and lower pressure, um, uh, like a surrogate of IPAP and EPAP. I'm sorry, IPAP min and IPAP max. And you can set a range of the inspiratory time. But once again, if you have a patient, for example, who is breathing rather rapidly and taking very small breaths, because it's targeting alveolar ventilation, for example, it may not necessarily ensure that adequate tidal volume per breath is being given. The advantage is that, patients, when they naturally breathe, can regulate and have some variation in their tidal volume from breath to breath. It's very important, therefore, that when we're choosing modes, that we're choosing the right mode for the right patient. And so it's very important to know the modes, and it's very important to know your patient. So going back to our case one, he comes back and we end up starting him on bilevel S, as we talked about. And he comes back to clinic at day 61. We review his data. He was on a Respironics bilevel S, and we looked at Cure Orchestrator, and we see that he has great adherence in the top left here of 9 hours and 14 minutes, and his um, three major parameters that I've circled here in red that I tend to follow. His AHI is low. He never had sleep apnea or concern for sleep apnea, so at least that's adequately addressed. But then we look at his tidal volume and respiratory rate. And so in reviewing that, um, typically we want to make sure that there's adequate tidal volume to his height, and which is about 550. And we also want to make sure that there is some amount of ventilatory rest. And some folks use this number called the rapid shallow breathing index, which we also use in the ICU when we're trying to extubate patients, which is a number calculated by measuring the respiratory rate divided by tidal volume in liters. And in his case, it's 30. And while this is not a guideline driven kind of thing that I currently follow, it's used in multiple studies to look at as a surrogate for ventilatory rest. And in patients, in one particular study where they compared patients with mild versus moderate ALS to more to controls, the controls had an RSBI closer to 35. So this is satisfactory for our patient. So I always like to differentiate what's guideline driven and what's versus not. And so I wanted to make sure I emphasized in red here that it's not guideline driven here. I'm not aware of any prospective randomized controlled trials that targeted RSBI to show benefit. So I just want to make you aware. So this patient, our patient, is readmitted within a month, and he is using his bilevel every day, all day. And his pH is still 728 with a CO2 of 112. And he gets treated for his exacerbation. And so what do we do now, right? And so definitely we'll have a goals of care discussion. And, perhaps given he's using it all day, he's still not, perhaps his condition has progressed. And this might be a good time to start, VAPS device. Um, I do want to actually highlight again that this is not a practice guideline based recommendation, but something I've done in the past. And now I've noticed that the OnMap technical expert panel, in their recommendation of when to convert to home ventilation that's more advanced, they do seem to discuss that if a patient is using their bi-level device for more than 10 hours a day, then we want to consider moving to a more advanced form of ventilation. So let's say we're ordering very specifically this Trilogy AVAPS device for him. We're not thinking about utilizing, again, we don't think that he has sleep apnea. So, what settings will we pick? And I just wanted to walk through what settings we might order. This patient is 5'8", and we'll talk more about his height. So, it picks an EPAP of 5, given that he has no sleep apnea and I didn't set a range. And, you could even go down to 4, particularly in the EVO, which goes down to a lower EPAP. And, you do want to be careful with patients with COPD, particularly when they're recent exacerbations. You don't want to set the EPAP too low because, you do want to account for if they have a high amount of auto PEEP. And so you may want to increase the EPOP when you're concerned about something like that where they have hyperinflation. With the Pmax and Pmin, this is a range, and so I picked a maximum pressure of 25 and a minimum pressure of 14. And his tidal volume I set to 550 based on his height, which I'll show in the next slide, and a respiratory rate of 10. You could choose a higher number if you'd like as well, and this just felt like a comfortable place to start for him. And the inspiratory time, typically for patients with COPD, they require a longer expiratory time to exhale more, and so we tend to put a shorter I time, whereas patients with neuromuscular disease just seem to really want that higher inspiratory time. We then set an AVAPS rate, and I picked the number 3. And so what do these settings mean, right? And so for this patient, based on these settings, every night his machine will start him at the equivalent of bi-level 14/5 with a respiratory rate of 10. And then the machine says, hey, am I getting my tidal volume of 550 cc's? And then if no, you're not getting those 500 cc's, well, I will increase the IPAP rate. And that's what the machine does over the next 2 minutes, because this is Trilogy, and it ramps up slowly. And so how much does it increase the IPAP by? It's the AVAPS rate. So then we add to 14, which was your minimum IPAP you set, you add the number 3, which is your AVAPS rate, which brings you to 17/5. And then the machine checks, hey, am I meeting my tidal volume goals? No, I'm not at 550. Let me increase my IPAP again by 3. So then you get to 20/5. And so it keeps ramping up that way till you get to your maximum pressure. The one thing to do is then follow up on your download after you start the patient on this, because let's say the patient comes back in a month and the tidal volumes are still only about 450 or so, something low, and the patient's maxing out at 25/5. It means that we didn't set that max pressure high enough to reach his tidal volume. And I know it's scary, but we might have to increase that Pmax for this particular patient. So follow your downloads, which, there was not enough time to talk about in this talk here. And so the way I chose this tidal volume is I go over to this ARDSNet table, which is easier for me, and I go over to the male side on the left, And I go to 5'8" and I walk over to 8 cc. It gives me like his predicted body weight, which is 68.4 kilo. And it gives me what 8 cc per kilo ideal body weight is, which is 550. Now, this is something that has been a practice that most practitioners tend to do. It's anecdotal, but I've seen studies, for example, for obesity hypoventilation that use 6 to 8 cc per kilo, 6 to 8 cc per kilo actual body weight as opposed to ideal body weight. So this is not a guideline driven or evidence driven kind of recommendation. Although we'll see some of the guideline statement from ASM later on about this. So, what is the role of the sleep lab in managing hypoventilation? And we'll go through a case to discuss that. This is a 37-year-old patient of mine with spinal muscular atrophy who presented to clinic to establish care. His carbon dioxide was normal at 40, and he said he was diagnosed with obstructive sleep apnea about 5 years ago when he saw a sleep physician. He had been on automatic CPAP, but continued to have orthopnea and morning headaches as well as sleepiness. And so his neurologist recommended that he come see us. And so, we checked his PFTs and his vital capacity was only 24. So, in reviewing his sleep study, it turned out that, he had events similar to this, described really beautifully by Dr. Abusowan in this article cited here. And so what this is that we're seeing that there is an absence of nasal flow, but there's also an absence of chest rise in these events circled. And they seem to occur during phasic REM, where we see phasic eye movements, which all of our sleep folks here will recognize. And these events seem to only occur during REM sleep, and he had no events during the rest of his sleep study, except in REM sleep. And so, what these are what are called pseudo-central apneas, and they are very suggestive of neuromuscular weakness. And it's that as progressive relaxation occurs in our accessory muscles of respiration, particularly in phasic REM, where those guys are totally paralyzed and the diaphragm is really on its own. That's when the inadequacies of the diaphragm come out and it just can't move the chest wall anymore. And so we might see a rise in CO2 during this stage if we had carbon dioxide monitoring here. And so, we should recognize these and not diagnose obstructive sleep apnea here, and note that this is characteristic of neuromuscular weakness. And so, what we ended up doing is discussing his goals of care, and given the severity of uh, the reduction in the vital capacity. And so, he was not interested in tracheostomy. And so, we discussed non invasive ventilation and recommended home ventilation that's more advanced. However, he was more used to his recent CPAP. And so, he really, really wanted to try bi-level S first. And so, it was ordered for him and here he is within a week. We were monitoring him on Care Orchestrator. I was able to click on the breath to breath data to take a look. And, each of these strips, for anyone who's not seen this before, so for example, next to 2:46 a.m., we see a whole row. That's about 6 minutes of his night. And each of these rows is 6 minutes. And what we see is there's these clusters of rapid shallow breathing where he's actually able to trigger his bilevel, but these other little hiccups where he's attempting to take a breath, but just not strong enough to set off the bilevel to push air into his lungs. And so what this is ineffective triggering while on bilevel S. So this gentleman was switched to the ResMed Astral ventilator, and the data that we're seeing here is from the AirView remote monitoring, the cloud system. And so he's set to a pressure assist control with safety tidal volume, the PACSV, and he's set to a pressure of 15 over 5 with a respiratory rate of 10. Um, he is set to a tidal volume of 400, and his eye time is 1.9 seconds. It appears that's what he wants. And ultimately, he had a usage of 100%, and his AHI is 1.5, obviously, because he has no obstructive sleep apnea to begin with. And his pressure seems to have landed at 14 over 5, 15 over 5 about, and his tidal volumes are rather large at 800 cc's. This is likely because of the large eye time that he's wanting. And a mistake I made here though is that I set him to a medium trigger when he's known to have a weakness, and part of me wonders whether the respiratory rate of 10 here is because he's happy with his tidal volume and minute ventilation, and so he's not tachypnic anymore, or whether it's because of the you know medium trigger, and it's not he's not able to trigger the ventilator. And so it just does make me wonder. So the role of sleep studies, what is the role here? I think the most important thing to keep in mind here is that, reimbursement for non-invasive ventilation in the absence of sleep apnea is not guided by sleep studies. And so, should we really be doing them unless we need them? And particularly if we do end up, perhaps suspecting sleep apnea, and if we do a sleep study, we certainly should be, aware enough to recognize what is not sleep apnea, and maybe a telltale sign of neuromuscular weakness, such as pseudocentrals. In the sleep lab, though, it can be very helpful to have a sleep study on a patient, such as someone who has shortness of breath and, I'm not seeing any true lung disease, and perhaps, the PFTs were not helpful in guiding which way to go, and perhaps the sleep test shows that the carbon dioxide is rising in REM, or I'm seeing pseudocentrals, and so it directs us more so towards hypoventilation and perhaps a neuromuscular disorder. Um, it's the sleep lab is also a great place for patients with obesity hypoventilation that are more complex than patients with just hypoventilation or issues with oxygenation, because obesity hypoventilation, they can have a issue with oxygenation, with ventilation, as well as the upper airway, and so there's so much to treat there, and that really needs to be done in the sleep lab. It is important that when these two disorders, the hypoventilation and sleep apnea, occur together, particularly for our techs, we do need to instruct them to treat the sleep apnea first, and unless the order specifically says bilevel, they need to titrate CPAP first. And we do need to specify, particularly when we have more than one modality, such as end-tidal and transcutaneous, what we want run in the sleep lab, and kind of knowing the advantages and disadvantages of both. Because end-tidal, for example, in a titration study, there might be leakage of leakage of air, and there might be a washout of carbon dioxide, making end-tidal not a good modality there. Or in patients who can't exhale the air from their lungs because they have hypoventilation, end-tidal may not give us a great accurate picture of what their alveolar carbon dioxide is, versus transcutaneous CO2, which doesn't give us quick data. Often there's a lag because of the time it takes to equilibrate with the transcutaneous, and also because of drift. And so we'll look at obesity hypoventilation guidelines in this case here, case number 3. We have a 48-year-old woman, hypertensive, with high carbon dioxide noted on her blood gas of 75. Her body mass index is 65. And so during the hospitalization, she's on non-invasive. For her acute respiratory failure, she's diuresed and blood pressure is controlled. And so what do we do with this patient at discharge? What do the ATS guidelines say for patients with suspected obesity hypoventilation? Do we send them home with advanced home ventilation? Do we make sure their heart failure is treated first, medically optimized, and then see them for an outpatient sleep study within 3 months? Do we discharge them with NIV and ensure outpatient sleep testing in 2 months? Or do we do bariatric surgery right away? And so the current answer is that we're supposed to send them home with NIV, ideally with a backup rate, and ensure that there's outpatient sleep testing done in 2 months. And, how about outpatient? If this patient has a sleep study and their AHI is 65, which of the following devices should we be treating this patient with first? Home ventilation, CPAP, bilevel S, bilevel ST, or ASV? And the correct answer is CPAP. So we need to show that CPAP has been tried and failed before advancing to more advanced ventilation. So the AASM has specific guidelines. Oh my gosh. Has specific guidelines for how to titrate non-invasive ventilation. I've provided the reference here, but I'll likely, not go through all of the things listed in detail. Overall, the goals of titration, are that we should talk about the indications with our patient and make sure that there's appropriate mask fitting. The ASM emphasizes that polysomnography is the proper way to manage all chronic hypoventilation. And this comes up on the next slide as well in point 6 and 7. And it does not align with the ATS recommendations. The goals of treatment should be to normalize carbon dioxide and improve sleep quality, and also to result in like ventilatory rest. And they suggest utilization of EMG, um, but perhaps there are other surrogates of ventilatory rest as well that they don't quite talk about there. And if obstructive sleep apnea is present, we should always titrate per the titration guidelines for a sleep apnea first. And point 6 and 7, once again, emphasize that the sleep lab should be used to titrate for all hypoventilation disorders, which again does not align with the ATS recommendation. So the necessary equipment is really all of the stuff that most of us have in the sleep lab, including the different modes of non-invasive ventilation and the ability to measure leak, as well as the pressure signals and airflow. But they also recommend utilization of transcutaneous or end-tidal CO2 and adequate mask variety and oxygen. The limits, they suggest starting at a minimum of a bi-level of 8/4 with a maximum IPAP of 30 for adults. And the pressure support can be anywhere. The pressure support is the difference between the IPAP and EPAP. That can be anywhere from 4 to 20. And changes in pressure support should be slow from 1 to 2. And so they recommend starting with documentation of your wake carbon dioxide while laying down. This is the ultimate goal to get close to this. and titrate the bilevel until sleep apnea is resolved first. And then they suggest slowly increasing that pressure support until either we resolve the hypoventilation as measured by carbon dioxide, or until the tidal volume is 6 to 8 uh, cc's per kilo, or until hypoxemia, the is resolved when the tidal volume is low. Overall, the goals of the titration are, determining, when you're doing a titration study or any even a diagnostic hypoventilation study, is making that determination. Do I need end tidal? Do I need transcutaneous? Do I, if I'm doing a split night study, make sure you run the diagnostic for sleep apnea. A common mistake, is that I've seen certain techs make is that, as soon as they meet the definition for hypoventilation, they start titrating bilevel, keeping in mind that reimbursement for NIV is not driven by hypoventilation. If your patient, particularly if you want to see OHS, you want to wait till at least that 2 hour mark of seeing if you have sleep apnea, or until you meet the split night criteria for sleep apnea. And then, in what if there is no sleep apnea found even after several hours? Should we be titrating for bilevel if the patient has another condition such as concurrent neuromuscular disorder or COPD? And so our techs were instructed not to titrate unless specific orders were provided. And part of that decision is that, if the patient does not meet criteria for NIV during the daytime, by a daytime criteria, then, there may be no reimbursement for the NIV, even with a titration. Secondly, if and the patient's insurer, even if the patient has hypoventilation by daytime criteria, they may or may not reimburse the cost for titration in the absence of sleep apnea. And so those are things to take into account when we're kind of instructing our partners, our techs in the sleep lab. So what we've reviewed today was pathophysiology of respiratory failure, what NIV can do, particularly with a focus on with mortality, and what the current guidelines for NIV initiation and reimbursement are, as well as the modes of non-invasive ventilation. And we walked through 3 cases of how to order and troubleshoot non-invasive ventilation. So this has been very fun. Once again, my name is Srilata Nayak. Please let me know if you have any questions. Good morning. My name is Dr. Srilata Nayak.
Okay, we are back